Hello students. Today I would like to take time to go through ICD-10-CM, the chapter for ICD-10-CM, diseases of the circulatory system. So today's lecture will go through the organization of the conditions and codes included in the diseases of the circulatory system diseases chapter, review the chapter-specific coding guidelines related to the circulatory system diseases, review different circulatory system diseases, and assign ICD-10-CM codes from this section or chapter of ICD-10-CM by reviewing a few different case studies towards the end of the lecture. So the great vessels of the circulatory system are the veins and arteries leaving and entering and leaving the heart again. They include the aorta, the vena cava, the pulmonary arteries, and the pulmonary veins. The heart and great vessels circulate the blood to the lungs for oxygenation and then throughout the body. The blood also eliminates waste products from the cells. If this circulation is stopped throughout the body, the cell also eliminates waste products from the cells. So here you'll see the different circulatory system code categories, and you'll see that they're listed here. I won't read them all to you because you can actually look at them, but those are the different categories that are listed within the circulatory system chapter in ICD-10-CM. So on the next slide, rheumatic heart disease occurs as a result of an infection with group A hemolytic streptococcus. So the first axis distinguishes whether the fever is acute. And when we talk about axis, it's kind of like the category for acute, and then or inactive, an axis for inactive or chronic is, the other category for chronic group A hemolytic streptococcus or rheumatic heart disease. So chronic rheumatic heart disease is a result of a previously active rheumatic infection. The heart valves are most often involved. ICD-10-CM presumes that certain mitral valve disorders are rheumatic in origin when the diagnostic statement includes more than one condition affecting the mitral valves, one of which is presumed to be rheumatic. All are classified as rheumatic. So for example, I05.0 mitral valve stenosis. The mitral valve stenosis is presumed to be of rheumatic origin. And then I34.0 mitral valve insufficiency. The mitral valve insufficiency is not. I05.2 mitral valve stenosis and insufficiency. The combination code presumes both to be rheumatic because the stenosis is presumed to be rheumatic, which is a disorder affecting both the mitral and aortic valves, is also presumed to be rheumatic in origin. So I08.0. Okay. Otherwise, the aortic valve condition is classified as rheumatic only when specifically stated as such. So if you have an aortic valve condition, just again remember it's got to be specified as rheumatic in nature in order for it to be picked up as such. So a diagnosis of heart failure in a patient who has rheumatic heart disease is classified as I90.91 rheumatic heart failure unless the physician provides documentation of a different causal relationship or causal effect. An additional code from I50 heart failure is assigned to identify the type of heart failure. However, do not make an assumption that congestive heart failure is rheumatic in nature. Unless ICD-10-CM directs the coder to assign the code for rheumatic, it is inappropriate to assign a code for rheumatic congestive heart failure. So again, you have to have that causal relationship there unless, in order to code it as a rheumatic heart failure. So just keep that in mind whenever it comes to rheumatic heart disease and ICD-10-CM. So ischemic heart disease is the general term for a number of disorders affecting the myocardium caused by a decrease in the blood supply to the heart due to coronary insufficiency. The insufficiency is usually caused by deposits of atheromatosis material in the epicardial portions of the coronary artery that progressively obstruct its branches so that the lumen of the arteries become particularly or partially or completely occluded. So some common terms you will see documented within the patient's medical record are arteriosclerosis or arteriosclerotic heart disease, also known as ASHD, and coronary ischemia or coronary artery disease, also known as CAD, or coronary arteriosclerosis, also known as atherosclerosis. So angina pectoris, that's on the next slide. So angina pectoris is an early manifestation of ischemic heart disease. Although in rare instances it occurs as a result of congenital abnormalities of the coronary arteries or such conditions as aortic stenosis, valvular insufficiency, aortic syphilis, and Raynaud's phenomenon. It is characterized by chest pain, usually perceived by the patient as a sensation of tightness, squeezing, pressure, choking, burning, heartburn, gas, or of an ill-defined discomfort. This type of angina can be produced by any activity or situation that increases the oxygen requirements of the myocardium, such as exercise or walking into the wind or cold weather. So the next one is unstable angina, and unstable angina includes conditions described as accelerated, crescendo, intermediate coronary syndrome, pre-infarction, or worsening effort angina. This occurs after less exertion than in angina pectoris. The pain is more severe and is less easily relieved by nitroglycerin. Without treatment, unstable angina often progresses to an acute myocardial infarction. So unstable angina is designated as the principal diagnosis only when the underlying condition is not identified and there is no surgical intervention. Patients with severe coronary arteriosclerosis and unstable angina may be admitted for a cardiac bypass surgery or a percutaneous transluminal coronary angioplasty to prevent further progression to infarction. In such cases, the combination code for coronary arteriosclerosis with unstable angina is assigned as a principal diagnosis, which relates to ICD-10-CM code I25.110. Some examples of appropriate coding will actually follow. So a patient was admitted with unstable angina and had a right and left heart catheterization showing coronary arteriosclerosis. A coronary bypass was recommended, but the patient felt he needed some time to think it over. So coronary arteriosclerosis with unstable angina I25.110 is the principal diagnosis in this specific case. So another example, a patient was admitted with unstable angina and had a history of a myocardial infarction or an MI 5 years ago. She was treated with IV nitroglycerin. The angina subsided by the end of the first hospital day. No other complications were noted and no additional diagnostic studies were done. Unstable angina I20.0 is the principal diagnosis. Code I25.2 should be coded as secondary to describe the history of the patient's old myocardial infarction. A diagnosis of acute ischemic heart disease or acute myocardial ischemia does not always indicate an infarction. It is often possible to prevent infarction by means of surgery and or the use of thrombolytic agents if the patient is treated promptly. If there is occlusion or thrombosis of the artery without an infarction, I24.0 acute coronary thrombosis not resulting in a myocardial infarction is assigned. I24.8 other forms of acute ischemic heart disease includes coronary insufficiency and subendocardial ischemia. ICD-10-CM has combination codes for atherosclerotic heart disease with angina pectoris. The subcategories for these codes are I25.11, atherosclerotic heart disease of native artery, coronary artery with angina pectoris, and I25.7, atherosclerosis of coronary artery bypass grafts in coronary artery of transplant heart with angina pectoris. When using one of these combination codes, it is not necessary to use an additional code for the angina pectoris. A causal relationship can be assumed in a patient with both arteriosclerosis and angina pectoris unless the documentation indicates otherwise or the physician states that the angina is due to something else other than the atherosclerosis. If a patient with coronary artery disease is admitted due to an acute myocardial infarction, also known as an AMI, the AMI should be sequenced before the coronary artery disease. So those are some important things to make sure that you know when it comes to coding, unstable angina, atherosclerotic coronary artery disease, as well as an acute myocardial infarction. So please keep those in mind. So moving on, an acute myocardial infarction is an acute ischemic condition that ordinarily appears following prolonged myocardial ischemia. It is usually precipitated by an occlusive coronary thrombus at the site of an existing arteriosclerotic stenosis. Although the ischemic heart disease is a progressive disorder, it is often silent for long periods with no clinical manifestations. And then it can just suddenly appear in an acute form without any intervening symptoms having been experienced. A myocardial infarction is described as acute or with a duration of 4 weeks or less, and is classified in category I21, ST elevation, or also known as a STEMI, and then a non-ST elevation, also known as an NSTEMI, myocardial infarction. Instructional notes have been added at the category level for I21 and I22, which state to use additional codes to identify certain health hazards, including TPA status and tobacco exposure, use, or dependence. Time parameters in ICD-10-CM related to the reporting of an AMI, or acute myocardial infarction, are now listed as 4 weeks or less. So for example, I21 ST elevation, also known as a STEMI, and then an NSTEMI or non-ST elevation myocardial infarction includes notes stating myocardial infarction specified as acute or with a stated duration of 4 weeks or 28 days or less from onset. So I22 category subsequent ST elevation STEMI and NSTEMI myocardial infarction includes a note states acute myocardial infarction occurring within 4 weeks, 28 days of a previous acute myocardial infarction, regardless of the site of the AMI. So just some notes to keep in mind is an AMI codes and ICD-10 specify the affecting coronary vessel. For example, an AMI documented as a subendocardial or non-transmural is coded as such. As I21.4 and I22.2, even if the site of the infarction is specified. However, if the NSTEMI converts to a STEMI, report only the STEMI code. If the STEMI converts to an NSTEMI, due to the thrombolytic therapy, it is reported as a STEMI. For example, I21.19 ST elevation STEMI myocardial infarction involving other coronary artery of inferior wall. So myocardial infarctions can also be classified according to whether they're an ST segment elevation or a non-ST segment elevation. If there's no information regarding whether there is an ST or non-ST elevation or information regarding the site of the myocardial infarction, coders should assign I21.3. So if a myocardial infarction is documented as non-transmural or subendocardial, but the site is provided, it is still coded as a subendocardial myocardial infarction, I21.4 NSTEMI. So a code from subcategory or category I-22, subsequent ST elevation and non-ST elevation, which is a STEMI and an NSTEMI, myocardial infarction, is to be used when a patient who has suffered an AMI has a new acute myocardial infarction within the 4-week time frame of the initial AMI. A code from category I-22 must be used in conjunction with a code from category I-21. The sequencing of I-22 and I-21 codes depends on the circumstances of the admission. So, for example, a patient who suffers an acute NSTEMI is readmitted 2 weeks later for a subsequent inferior STEMI or myocardial infarction, code I-22.1 subsequent STE elevation or STEMI myocardial infarction of the inferior wall, and I-21.4 non-ST elevation myocardial infarction are both applied. The sequencing of the admission or the code, the AMI codes, is basically determined by the circumstances of the hospital admission. So if a patient is admitted for an acute myocardial infarction but has a subsequent AMI while in the hospital, the initial I-21 code would be sequenced first as the reason for the encounter and the admission. The I-22 subsequent AMI code is sequenced as a secondary diagnosis. So just keep this in mind. All of these things are actually documented and noted within your ICD-10-CM coding guidelines as it relates to acute myocardial infarction. So I won't move on. There is other documentation or other information related to or pertaining to acute myocardial infarctions within your coding guidelines. So please make sure that you're reading and reviewing that material and that information within that chapter or section of ICD-10-CM coding guidelines. So next is hypertension. So the classification presumes a causal relationship between hypertension and heart involvement and between hypertension and kidney involvement, as the two conditions are linked by the term with in the alphabetic index. So these conditions should be coded as related even in the absence of the provider's documentation explicitly linking them unless the documentation clearly states the conditions are unrelated. So for hypertension and conditions not specifically linked by relational terms such as with, associated with, or due to in the classification, provider documentation must link the conditions in order to code them as related. So basically hypertension, if you see documentation of hypertension and the patient has heart disease, those can automatically be coded as hypertensive heart disease. The same thing with a chronic kidney disease. If you see a patient has hypertension as well as chronic kidney disease, it would be coded as hypertensive chronic kidney disease. So within ICD-10-CM, hypertension with heart disease presumes a cause and effect relationship with the chronic kidney disease as well as the heart disease. So hypertensive heart and chronic kidney disease. So there's a combination code for I-13 for hypertensive heart and chronic kidney disease when the hypertension with both heart and kidney involvement. So if heart failure is present, you want to assign an additional code to identify the heart failure. So hypertensive cardio or cerebrovascular disease. For hypertensive cerebrovascular disease, that requires two codes. You first assign the appropriate code from categories I-60.9 to I-69, followed by the appropriate hypertension code. Hypertensive retinopathy requires two codes as well. One code from the appropriate subcategory H35.Z code, background retinopathy and retinal vascular changes, and then a code from the hypertensive section. So the sequencing is based upon the reasons for the encounter, whether you go with the hypertension first or the retinopathy first. So just keep that in mind and pay attention to the reasons for the admission and the principal diagnosis selection guidelines. So hypertension secondary. Secondary hypertension is due to an underlying condition. Two codes are required, one to identify the underlying etiology and one from the category I-15 to identify the hypertension. Sequencing of codes is determined by the reason for the admission and the encounter. So hypertension transient, assign code R03.0, elevated blood pressure, reading without diagnosis of hypertension unless the patient has an established diagnosis of hypertension. So assign code 013, gestational pregnancy-induced hypertension without significant proteinuria, or 014, preeclampsia for transient hypertension of pregnancy. This condition is not synonymous with systemic hypertension. So then hypertension is also broken down into transient and controlled and uncontrolled. And then you'll also see there's another category that's listed out there for hypertensive urgency. So all of those things, again, depend on how the doctor has it documented. Just be sure that you're following the physician documentation closely and then reviewing the main term within the ICD-10-CM index, and again referencing that code to confirm the code and the tabular, ICD-10-CM tabular, which is in the back of your ICD-10-CM coding manual. So next we have cerebrovascular disease, and medical record documentation should clearly specify the cause and effect, relationship between the medical intervention and the cerebrovascular accident in order to assign a code for intraoperative or post-procedural cerebrovascular accidents. Proper code assignment depends on whether it was an infarction or hemorrhage and whether it occurred intraoperatively or postoperatively. If it was a cerebral hemorrhage, code assignment depends on the type of procedure performed. ICD-10-CM classifies the late effect of cerebrovascular disease as a sequela to category I-69. Sequela codes specify the residual effect that remains after the acute phase of the previous illness or injury. So, for example, if someone comes in and say they have speech and language deficits, or they're having cognitive deficits, or hemiplegia or monoplegia that's related to affecting one side of the body, or right-sided weakness, then you would code the late effect or the sequela code. Note that instructional notes prompt the coder to use the additional codes that identify certain specific syndromes or conditions such as paralytic syndromes, dysphagia, or other sequela for reporting the condition in its entirety. So, for example, if a patient came in, they had dysphagia following non-traumatic subarachnoid hemorrhage, you would use an additional code to identify the type of dysphagia, and you would also code the dysphagia code following non-traumatic subarachnoid hemorrhage as well. So there would actually be two codes there based off of the coding guidance that's provided within that subset of codes. So there's no time limit restricting the reporting of sequela codes. Residual conditions may occur months or years following the causal condition. So two codes are often required. The condition resulting from the sequela is coded first, followed by the appropriate late effect code for the sequela. Codes from category I-69 may be reported with codes from I-60 through I-67. So when current cerebrovascular disease and residual deficits from an old cerebrovascular disease actually coexist. So someone can come in with a new CVA or cerebrovascular disease or stroke, and then still have previous deficits from an old stroke. So you can definitely code both of those things together. So when a patient presents with a history of a transient ischemic attack, or also known as a TIA, or cerebral infarction without residual deficits, then you would report Z86.3. Then we just kind of go into the sequela categories of a CVA. So just make sure that you take time to go through those. It just basically talks about should the affected side be documented but not specified as dominant or non-dominant, and the classification of systems does not indicate a default code. Selection would be for ambidextrous patients, the default should be dominant, and for the left, if the left side is affected, the default is non-dominant. If the right side is affected, the default is dominant. So those are just some important things to remember when it comes from a sequela of CVA coding perspective. So within this next section, you will actually be practicing coding and looking these conditions up within your ICD-10-CM coding manual. So you want to make sure you reference, first off, ask yourself what is the main term that you would reference here, and in this case it would be prolapse. So we would want to turn to prolapse. Within our ICD-10-CM coding index, which is going to be, if you have the Optum ICD-10-CM Expert Edition for 2017, it should be on page 264. And then the site that we're looking for is mitral valve. We might have to go to heart. Or actually we might need to start with instead of prolapse because we're not coming with it. So let's go to mitral, or actually valve. Let's try valve. And sometimes this is the case when you're looking these things up, is you have to reference a couple different terms to ensure that you're following the correct path. So valve is not the correct thing, so I would think prolapse, but let's try mitral. And again, it says C condition, so it's got to be under prolapse. I may be just looking at the wrong page. So let's go back. So prolapse is the correct main term. And it looks like when you go to organ, no, there it is. It's right under my face. So mitral, and then valve. You see valve is in parentheses. So it is, valve is considered a non-essential modifier. It can be present or absent within the documentation provided by the physician. So the correct code there is I34.1. So you want to turn to I34.1 in the back of your ICD-10-CM coding manual in the color-coded pages. Just to validate, we said I34.1. So you see it's non-rheumatic mitral valve prolapse. So that is the correct code for that condition. Okay, I34.1. So we'll go to the next one. Type 2 atrioventricular heart block. So we can start out with block as your main term. So you want to reference block within the front of your ICD-10-CM index to diseases. And then we said atrioventricular heart block, so we want to go to block atrioventricular, and we said it's a type 2. So go down to where it says block atrioventricular, type 1 and 2, codes to I44.1. So we want to reference I44.1 in the back, in your tabular listing, in the color-coded pages in the back of your ICD-10-CM coding manual. So I44.1. Atrioventricular block, second degree. So, and then you also see below it, it says a Mobitz block type 1 and 2, second degree block type 1 and 2. So it includes type 1 and 2. So the things that's written under I44.1 and not in bold, but directly below it, that just shows the different codes that are included within that, that section of ICD-10-CM. Okay, let's go to the next one. So this one says a patient with a history of mild controlled hypertension presents with an acute cerebral stroke due to non-traumatic hemorrhage. So we'll start with stroke. And let's see. Oh, actually, we need to go to, because it's actually the same thing as a CVA. So we want to do infarction, cerebral. So infarction should be your main term. Then cerebral would be the subterm. And we said due to a non-traumatic hemorrhage. So infarction, cerebral, due to we said a hemorrhage. So due to hemorrhage and thrombosis are the same thing. So you want to go to, and it's the cerebral, let's see, is it the cerebral? Just says cerebellar. Let's see. But you notice under cerebellar, it says C infarct cerebral. Then cerebral says C also occlusion, artery, cerebral, or pre-cerebral with infarction. So let's go to that, the C also note. So occlusion, artery, cerebral. So we'll go occlusion as our main term. And sometimes you have to just do this to go around, so I'm glad we were actually demonstrating this one for you. So we said cerebral. Now occlusion is the main term, artery, then cerebral, with infarction, due to thrombosis. Let's just go to I63.3. Just want to make sure that that's the one that includes the actual hemorrhage, non-traumatic hemorrhage. So I63.3 in the back of your coding manual. Okay, so now we're, let's see, looking for so I63.30 is cerebral infarction due to thrombosis of unspecified cerebral artery. Trying to find one that actually includes the, that's probably going to be the best that we get. But let me try one other way to do a hemorrhage. We'll try hemorrhage as the main term. We said I-63.30. So let me write that down. Okay. Okay, so I-63.30 is the code. Cerebral infarction due to thrombosis of the cerebral arteries or unspecified cerebral artery is the appropriate code for this condition. Okay, so the next one is acute on chronic diastolic congestive heart failure. So you'll want to go to failure as your main term in the front of your ICD-10-CM manual. Look for heart, and then congestive, or actually you can do, we said acute on chronic diastolic. You want to go to failure, heart, diastolic, and then acute, and on chronic is I-50.33. You want to reference I-50.33 in the back of your ICD-10-CM coding manual just to make sure that you have all of the required codes or characters for that specific code. So I-50.33 it says acute on chronic diastolic heart failure, so we know we have the correct code. Okay? Next one, stage 3 chronic kidney disease, hypertension, mild chronic heart failure. So that's going to be hypertensive, heart, and kidney disease. So it'll be 2 codes. So you'll want to look up the hypertensive condition first. So hypertensive kidney, so we want to do hypertensive kidney with heart disease. You can see hypertension, cardiorenal. So we can go hypertension, cardiorenal, and it says with heart failure, and then with stage 3. So this says it starts, so hypertension, cardiorenal, it has with heart failure, with stage 1 through stage 4 chronic kidney disease is I-13.0. So we want to code I-13.0 for the hypertensive component. Then you want to look up a code for stage 3 chronic kidney disease. So you go to disease, kidney chronic, and we said stage 3 is N18.3. So you want to reference that in the tabular. Yep, stage 3, that's correct. Chronic kidney disease. Next, we want to code the chronic heart failure. So you want to reference failure. And you can pause at any time if I'm going too fast. Failure, heart. So you see it's I-50.9. There is no indentation for chronic. So I-50.9, and you reference that in the tabular listing. So you have 3 codes. You have the code for your hypertensive, heart, and kidney disease with heart failure. You have your stage 3 chronic kidney disease code, and then you have your mild chronic heart failure code. Okay, so last but not least, please feel free to reach out should you have further questions. Thank you. Have a great day.